Hi, welcome to the poster presentation for Validating a Brief Confidence and Coping Measure for High Acuity Mental Health Populations. My name is Alex Danvers, and this is a project with myself and Sandra Norman Smith. We both work at Sierra Tucson, which is a large residential mental health facility in Tucson, Arizona, and I also have an affiliation with the University. The goal of this project that we did was to assess confidence in coping skills in our large residential mental health facility. We provide data to clinicians to help them with treatment planning, and assessing confidence in coping skills can be a helpful part of getting a more complete picture of a patient, which allows our clinicians to help create individualized treatment plans, which is one of the strengths of Sierra Tucson's treatment model. In particular, what we were trying to do is create a very brief coping scale that can be used side by side with a wide battery of tests, and that basically patients will be willing to take this and that the burden is not too high on them. We collected data from 1,159 individuals at our residential mental health facility. To give some background on this population, we primarily see people for addiction and co-occurring disorders. We see people for mood recovery, so depression and anxiety can be common among our residents, and for trauma recovery. So people who have PTSD often end up here in our trauma program. There's also a substantial portion of our population that are veterans and first responders. And those are often more complicated cases and slightly older individuals. The statistics for our population, the demographic statistics, are 44% female, 54% male, 2% non-binary or did not respond to the gender question. The average age is 40.6 years with a standard deviation of 15.3. Race and ethnicity data were not collected as part of this assessment. The reason we're really interested in using a coping scale is because coping is an important construct in mental health. So there's a nice review in the annual reviews of clinical psychology by Taylor and Stanton in 2007 that highlights the correlations between coping skills and mental health, which are strong, and highlights the fact that coping skills are a good target for intervention. There's also theoretical work by clinicians suggesting that actually helping clients develop coping skills is a key part of therapy. And in fact, this article by Goldfried suggests that what we essentially want to do in therapy is teach coping skills, is teach skills that residents can take forward with them in order to not continue to have their symptoms once they've ended the relationship with a therapist. We created this scale based primarily off the template of the coping self-efficacy scale, which is a longer scale. It's over 20 items, and it has 3 factors. One for coping with emotions, one for coping with problems, and one through social coping. We created all new items, but based on this factor structure that were more appropriate for this patient population, and also that in discussions with clinicians seemed relevant and helpful for them in their own work. So this is definitely an adaptation of the CSC, but one that has been tried to take into account the needs of this more acute clinical population. Here are the 9 items that we ended up using. And I will just read examples from each of the subscales. So an example of an emotion item: when things are not going well, I am confident I can think positively about myself. An example of a community item: when things are not going well, I am confident I can get help from family and friends in dealing with negative feelings. An example of an item related to day-to-day problems: when things are not going well, I am confident I can divide a big problem into smaller parts. Now we conducted a confirmatory factor analysis on this data. All this data was collected at the start of residential treatment. Typically we will have people complete the scale within 48 hours of starting residential treatment. The standard CFA indices show good fit. So we've got the CFI, the TLI, RMSEA, and SRMR here, all showing good measures of fit. The chi-square test of model fit was significant, so there are some more sort of strict or severe interpretations of SEM that suggest there could be a better fit to this model, but this matches many of the models that are currently used in the literature. You can see in this graphic the standardized paths between the various subscales. It's worth noting that there are high intercorrelations between all of the subscales. So for example, the coping with emotions and coping with problems subscales have a correlation of about 0.7. The correlation between community and emotions is about 0.6, and the community and problems correlation is about 0.5. So there is definitely some kind of core confidence in coping overall, but there seems to be enough separation that we believe we can justify looking at these separately. The other thing that we did is we correlated these three coping scales, or confidence in coping scales, with the several other measures from the battery of assessments that we give to residents at the start of their treatment in residential. And the typical pattern was one where emotion coping is the most strongly correlated with the kind of clinical outcome measure. So if you look at, for example, the first row, it shows that it is negatively correlated at 0.67 with depression. And then the other two scales tend to be slightly less related to the outcome measures. So for depression, you can see problem coping is negative 0.41. For community coping, it's negative 0.43. In general, we found an expected pattern of coping. Emotion coping is strongly and significantly negatively correlated with symptoms. It's positively correlated with quality of life. And when you break out the World Health Organization quality of life scale into its 4 subsections, the one that it's most strongly correlated with is the psychological quality of life. That's no surprise. Coping with emotions is most closely related to the construct of psychological quality of life as opposed to physical, social, or environmental. Coping with problems also has a similar pattern of correlations, but slightly smaller in magnitude. And then coping with community, similar to problem coping, it is a little bit more highly correlated with social quality of life, as we'd expect, and it tends to be negatively associated with the symptom measures and positively associated with the quality of life measures. With that, I will encourage you to consider coping in any of your clinical assessments and outcome measures, and I will leave you with our references. Thank you for your attention.